to hear from Dr. Martha Twaddle now. She is a clinical professor of medicine at Northwestern University's Feinberg School of Medicine and is a board certified in internal medicine and hospice and palliative medicine. Her presentation today is titled Palliative, Hospice, and End of Life Decisions, Reframing the Discussion. Please see her full bio in the program section of the meeting platform, and make sure to continue to submit your questions in the question box on the right-hand side of the screen. Dr. Twaddle, thank you so much for joining us.
Hey, it's so good to be with you this afternoon. I'm super grateful to be here. Can you hear me okay and see my slide? Oh, not a good sign. Hold on. Hold on. Something's going on here. Okay, what's going on? Are you able to hear me okay?
Oh, yep, you're still with us.
Okay, I wasn't sure. Okay, all right, I'm ready to go then. Sorry about that. I just want to be sure I was in the right place and had my slides up. Hold on.
Yes, you are.
Okay, here we go.
But we're not, yep, and there are your slides. All right,
Great.
I'm going to step away. The floor is yours.
All right, thanks, Amy, and the whole team. So we're going to take a tour of a very, very important topic of palliative medicine and hospice and all this. And you know what? I'm not able to drive my slides. I'm not sure what's going on, y'all, but it's not forwarding. Do you know? Nope, here we go. Sorry about that. We will get this going. All right. So this first slide is not my needlepoint. It's a very pretty slide. And actually what it's called, this is a mortality map. And the purpose of me putting this up here is not just because it's so pretty and fascinating. What this shows is how different illnesses increase in terms of how they contribute to mortality. And really, my overall purpose in showing you this is to notice that 100% is true for the whole thing. Really to emphasize that none of us get out of here alive. And although it's a tender area of discussion to consider our end of life, and as we get older, even more so, it is so critically important. We're really good about planning for our births, weddings, all sorts of wonderful life events. And yet most of us, the vast majority of us, do not prepare for what it would mean to live with a serious illness or frailty or increased need for support. Very few of us prepare for our end of life, for our death, for funerals, even talk about that with our family. If you survey folks, 80% of people will tell you it's super important to do this, but less than 25% of folks will actually do it. So in the course of our time together, what I'd like to discuss or present to you are some of the definitions of what am I talking about? and then when do I think about these things? When are these topics important for me to think about? And there'll be a few takeaways that I'll really reinforce. Where do I want to be and who do I want to have with me are some of the key issues, and why should I even consider this? And honestly, the most important thing we can do for those who we love and who love us is to plan and to discuss these. And I have lived this many times over with family members as well as patients that I love. And I can tell you with great confidence that the more folks talk about this, the more they plan, the gift they give to those who love them is enormous. There are some great publications out there. I get a big kick out of this one by Roz Chass. Somebody took off with my copy and I got to get another one. This is like my third. It's a comic book, but it's actually quite good about trying to talk to family members about advanced care planning. One of my beloved friends, BJ Miller, published a book a few years ago called The Beginner's Guide to the End, which was somewhat in response to what to expect when you're expecting. I published this with Shoshana Berger. It's very practical. It's an excellent book to have and to read, and someone ran off of my copy as well. When I show this picture, I know I'm very much dating myself because I grew up with black and white televisions with movable antenna and Marcus Welby on the television. But yet the Marcus Welby phenomena of believing that we have a healthcare system that really cares about us is endemic. We hope we believe that the this healthcare machine in the United States is really poised to take care of us. And the reality is that it is and it isn't. And we have to create within it breaks and guidelines and guardrails, and we have to have advocacy in the system, particularly as we become more and more frail or we're in positions where we can't really advocate for ourselves. I feel like sometimes when we hit that ER door or get admitted to the hospital in particular, it's kind of like a luge ride. The outfit's different. It doesn't fit so tight. It's not Lycra. But the number one thing that people will tell you when they're in a situation like that is that they feel very much out of control. And that's why I'm talking about these things as tender as they are, because this is really about facilitating and empowering people to have control and direction to the degree they can, even when they are ill. Our healthcare system is multidisciplinary. I'll explain how that differs from other types of team. It's specialty driven. It focuses on trying to treat and eradicate illness. And it is very much a biomedical model of care. I could talk long about, Plato and Hippocrates and the schisms that occurred that separated really the greater whole person care in the time of Descartes from the rest of care. Bottom line is, though there is tremendous outcomes and advances that have happened in a biomedical model, we are not biomedical. We are people. And when we are ill in particular, the vulnerability and the experience of illness can be significant. And so to the degree that we can anticipate, shape, and control and direct what happens to us and for us in that time is so critically important. There have been some great writers who have spoken to this. This is one of my favorite articles by Eric Cassell, published back in '82, when he talked about really we have two obligations. We have an obligation to try to cure disease when we can, but we also have an obligation to relieve suffering. And we can't relieve suffering if we don't understand what suffering means to each individual, because suffering is unique. So I love this language in particular. This is from Harvey Chochinov. I should put his name on the slide. Dr. Chochinov is a psychiatrist in Canada. It's just a magnificent person who is really the gentleman who developed dignity therapy, which has been published. There's so many hundreds and hundreds of articles on dignity therapy. It's taught as a means to facilitate support. I love this. What do I need to know about you so that I can take the best possible care of you? If I'm, I ask that and I teach my students, this is what I want you in every time you meet a new patient, and revisit this throughout the time that you're caring for someone. And it isn't just that person who is ill. The reality is it is the experience not only of those who are ill, but those who love and care for them. And the ramifications of illness are not just about the person who is ill, but the persons who are part of their care team. And we know, and from the literature, that being a caregiver is a highly risky business, and therefore those folks need to be equipped and supported as well. This amazing woman, Dame Cicely Saunders, was really the pioneer of reinforcing what we call whole person care back into the biomedical model. She started her career as a nurse, injured her back, became a social worker, and then went to medical school. And we joke that if Saunders had done chaplaincy training, she would have been a complete interdisciplinary team in and of herself. She would have met all the regulations. Saunders was not the creator of hospice. She was the person who moved hospice as a phenomena, as an approach of care into a more modern definition. Hospice care, as Saunders developed around the time of World War II, was focused at the relief of suffering. What I said, one of our major obligations, promoting quality of life, and it was a approach to those whose serious illness was so far advanced that they no longer were benefiting from disease directed treatments. In fact, to continue to treat the disease created such collateral damage, so to speak, that we needed to forego that. And we needed to very much focus on the person who was ill as opposed to the disease that they carried. And not just to focus, to really focus on the whole person, body, mind, and spirit, as well as attention to their family, chosen or biologic, as part of this care experience. And by doing so, we began to see some pretty remarkable outcomes. Hospice care is typically introduced when a person's prognosis is defined in terms of months as opposed to years or decades, and very much when the goals of care are about just keep me comfortable, just help me to experience quality of life. I'm not in the mode of trying to treat this illness any further. It isn't helping me, it's actually hurting me. Or when a person, because of their illness and sometimes what we call comorbidities, experiencing things such as weight loss, cognitive changes, deterioration in eating, and also when their care needs are increasing substantially and the family needs more help. Now, Saunders' first hospice and the hospices of Europe are often institutional. She didn't establish it, it was actually there, but she bolstered and strengthened St. Christopher's Hospice in London to be a research and teaching institution for hospice care, and also where palliative medicine, my discipline, um, was nurtured to grow. Now, let me explain a little bit of how we got to palliative medicine, because this is actually, I find this stuff fascinating. So this little powerhouse, Florence Waldman, took a deep breath. I think she was maybe a little over 5 feet tall, but wow, what a mighty soul. Florence Wald was the dean of nursing at Yale, and she befriended Saunders and wanted to incorporate Saunders' concept of hospice care into the United States. So this is about just prior to 74, 75, that era. And she and Saunders worked together at Yale to start a hospice program. It, as is typical when things come to the US, they get changed. So the model that Saunders had to have institutional based care quickly changed to a home care program, home delivery, home visits. And that's what then became a demonstration project. And that's what then became the law. So this picture is the group of folks who are part of the signing into law of what became the Medicare hospice benefit, which started with Dean Florence Wald and Saunders' demonstration project at Yale, and it became part of our Medicare portfolio. And the Medicare hospice benefit is a federally regulated insurance benefit that has conditions of participation that are written into the Code of Federal Regulations. What's interesting in it, I think I dreamed this stuff, is it mandates that care is provided by an interdisciplinary team, not a multidisciplinary team, and there's a difference. It also mandates the involvement of volunteers, which is absolutely fascinating. 5% of patient care hours need to be provided by volunteers. The hospice medical director plays a pivotal role. I served as a hospice medical director in a community-based nonprofit for 28 years. And then it also has commercial insurance also mimics the Medicare hospice benefit. It serves as kind of the template for most of the insurance products out there that provide hospice support. To be eligible to use this benefit, and I'm speaking specifically of the Medicare hospice benefit, not so much commercial, is that you have Medicare Part A, and that a physician, ideally two physicians, have deemed that your illness, your disease is in its terminal phases. And Medicare has defined terminal illness, not we haven't defined it as such. Medicare defined it as a prognosis of 6 months or less if the disease follows its typical course. So they certify that you are more likely to die in the next 6 months, sadly, than to survive. And you receive care through this Medicare approved hospice program. And Medicare covers everything 100%, the drugs, the visits, the equipment, everything related to the terminal prognosis. It's probably one of the most bountiful insurance benefits out there. So I started as a hospice medical director when I was still chief residue, as I called myself, at Northwestern in 1989. I did it as a volunteer, and I really love the work. I love the emphasis on the whole person, the emphasis on the family. It so enhanced my internal medicine practice to learn about symptom management and caring for people who are seriously ill. But what deeply troubled me was, why in heaven's name were we waiting till people were dying, essentially, to talk about quality of life and goals of care? It's like, why are we waiting? This is so beautiful and important. Can't I have these conversations, like with all my patients, number one, but certainly with any person who is confronted by a serious illness? Shouldn't we be talking about what is suffering? What is quality of life? What are you hoping for? What brings you joy? Can't I know those things right away? So I knew I was not the initiator of such thought. I knew there are great thought leaders out there who are asking the same question. And in my, fortunately, I found this gentleman, as many of us did, Dr. Balfour Mount, who was a urologic surgeon at McGill in Montreal. And Bal had studied urology. Then he went to Memorial Sloan Kettering in New York to study oncology surgery. And then he liked to say, I went across the pond and I worked with Cicely. He spent a good amount of time in London with Dame Saunders. And he came back to McGill with this concept. He was very captivated, as am I, by this hospice model of care, but he wanted to incorporate this at the time of diagnosis. He didn't want to use the term hospice. Hospice in French-speaking Quebec means a halfway house. And obviously, most people think of hospice as you're in the terminal phases of illness. We're talking about introducing the concept of whole person care, a biopsychosocial spiritual model of care at the time of the diagnosis to support a person and their family. And so he is the one who coined the term palliative care, which means to protect, to wrap, to enshroud, to help carry people through and protect them from the ravages of their illness, to alleviate suffering, but not just when people are at the end of life. So palliative medicine has become a specialized holistic medical discipline. Val shared his idea with Saunders. She loved it. They coined the term palliative medicine in the UK as well. So palliative medicine is the specialized medical care. Palliative care is the team, the interdisciplinary team that focuses on enhancing and improving quality of life and relieving suffering through symptom management, through spiritual and emotional support, guiding the practical solutions to a very complex and fragmented healthcare system, and helping support people as they navigate and make decisions about their care. It is interdisciplinary. So the difference between multidisciplinary, and I'll give you a nice little diagram of this in a minute too, is that this is a team. I use the analogy of the hand. An interdisciplinary team is like the hand versus wedges of a pie. A multidisciplinary team is a pie where we're all in our role. We chart in the medical record, we do our job, but we stay in our role. In an interdisciplinary model, we share in the screening for distress. So a social worker might screen for physical pain or a shortness of breath, and then ask the medical folks to go deep dive into assessment. I, as a physician, may screen for spiritual distress and suffering, and then ask other team members to also provide input and assessment. And this wonderful team therefore gives a greater perspective of the essence of it, of the human being who is experiencing this illness. And we work as a team with them as the center of our team to develop a vital and supportive plan of care. So palliative care integrates into curative care models. We're not yet another specialty, one more person to go see. We actually are the specialty that integrates and creates team and helps people better communicate. Um, Helps internists and cardiologists and pulmonary docs and renal docs and especially oncologists to have a team approach and more resources to care for their folks who are facing serious illness. It's not about prognosis, it's about need and risk. At Northwestern, we call ourselves palliative medicine and supportive care. That's our PMSC, is our title. And as you can tell, I hope that hospice is different from what I'm talking about. So, hospice is a form of palliative care supported by a specific insurance benefit for people who are in the terminal phases of their illness. It's also provided by a team. It's palliative care, but it's palliative care for those who are in advanced end stage illness and typically receiving that under a insurance benefit. So all that is hospice is palliative care, but all that is palliative care is not hospice. Palliative care ideally starts at the time of a diagnosis. So when the kidney cancer is first diagnosed, irrespective of its extent of disease, that's a life-changing event. That's the neutron bomb that went off in life. That changes everything. We move from well baby to now I got a diagnosis, and this is scary. So talking about some of these things, what their implications are, dealing with symptoms, planning for perhaps a nephrectomy or treatments, whatever it looks like, really, it really helps us if we know we've got, as I call it, a posse of people who are leaning in, eager to help, kind of one call, and they fan out to get all the other specialists involved and aligned and communicating, collaborating, cooperating. Is this helpful? So probably this article that was published in 2010 was probably the most seismic event in our field. This was Vicki Jackson and Jennifer Tamel, beloved colleagues at Harvard, who published this article, and they were studying non-small cell lung cancer and the effects of palliative care. It was a beautiful study, 3 years, randomized, matched controls. One group received standard oncology care at Mass General, and the other group received oncology care plus the palliative care team met with them when they came into clinic. That was the extent. It was a clinic-based model. It was an ambulatory model. They followed these folks for 3 years and looked at the outcomes. They found that people who received palliative care generally had an improved mood on measured scales, improved quality of life that was measurable, more documentation around advanced care planning, including whether or not they wanted to be resuscitated. The vast majority of these individuals chose less aggressive interventions at the end of life. But what dropped everybody's jaw is those who received palliative care in the clinic alongside standard oncology care lived significantly longer than those who just received standard oncology care. So if I'm a drug and I improve the well-being of people, their quality of life, they help them feel better and also help them live longer, you would think I would have a multi-billion-dollar sales record. Still getting people to access this support is sometimes difficult because they have these preconceived notions that palliative care is the same as hospice, which I hope you understand now it is not. And that somehow if I use palliative care, I'm not going to have the same treatments. Well, you're going to get the same treatments. The difference is you're going to get more and ideally integrated care that helps support you in your treatment. And this is how, again, I see the typical healthcare model. We're in our swim lanes, we're in our role, we're doing our flip turns, whereas palliative care is Esther Williams, for those of you who know who I'm talking about. The person and their family are in the center, and we are trying to communicate, coordinate, collaborate to create a support system around them. There are no swim lanes. It is all about helping people have the best care experience possible and to live well. So, one of the things that we do, where I like to take us, because this is very practical application of part of what is palliative care, and that is, again, planning and talking to those we love about what's important to that. And that's usually captured in this term advanced care planning or advanced directives. And this is housed very much in the Western ethic of people have the right to make decisions about themselves. They have the right to refuse treatments. They have the right to accept treatments. We respect autonomy and bodily autonomy and integrity. And advanced care planning allows us to put forth our values and how we make decisions and what decisions we're making that will carry forward even when we're too ill or to speak for ourselves. And it helps us to delineate who's going to be the spokesperson in the event that we are too ill. There's lots of different types of advanced care planning documents. I just want to touch on those. The most common and the most important is the healthcare power of attorney. Now, a lot of people don't realize that as soon as you turn 18 years of age, you're supposed to pick a healthcare power of attorney. I don't know a lot of 18-year-olds who do that. It would be nice with driver's license if we're recommended to do this, just like we're asked about donor status. Who's your healthcare power of attorney? Who's the person who can speak for you in the event that you are too ill? Very, very important to establish, and certainly in the event that we become ill and we have a diagnosis or serious illness where the illness is beginning to have an impact on our ability to function. So this is a continuum. First thing that we really need to do is identify that champion. So one of the tools that's out there that helps us identify our champion, as well as to give some direction to that person as to what we value, is a document called 5 Wishes. Now you're probably wondering, why the heck is there a picture of Mother Teresa? She didn't write 5 Wishes, but Jim Toohey did, and Jim Toohey was one of her dearest confidants and friends and served as her personal lawyer for a number of years, and still working in education. I think he's in Florida now. Jim created this document that in the first couple of pages, there is a healthcare power of attorney form that is very much accepted, and I'll explain why. And then the wishes are things that you want not to have happen to you if faced with certain medical situations. And what I love about this document is it also has things you would like to have happen to you, things that you find beneficial. Like mine says cello music and dark chocolate and red wine and porter stout. If I can't, those are things that bring me pleasure and joy. Turn off the doggone TV and no high-pitched sopranos with vibrato. I'm serious. My 5 Wishes has that level of detail in it because those are things that are important to me and provide me with comfort or create distress. And I want the person who is making decisions for me when I'm frail to be able to advocate for what brings me joy. Your healthcare power of attorney should be someone who knows you well, someone who understands, who gets you, who sees you, and can advocate for you. Someone who wouldn't be uncomfortable to question or push back or rebuttal the healthcare team that's well-intentioned but might not know you and might not understand what brings you distress or what brings you joy. and would be a conduit of your voice in that in the situation where you cannot speak for yourself. They have to be at least 18 years old. When we establish this person, we need to tell them that they're in this role. So going back to my 5 wishes, just really briefly, when the first time I created it and took it to my family, and I was explaining these things to my husband and my 2 kids. My kids were then teenagers. My son was only 13. And my daughter was 17. And my daughter and my husband were pretty grossed out by the whole discussion. It was just, ugh. They don't like talking about these things. They don't like medical stuff. My husband turned practically white. Now bless his, his heart, he is my healthcare power of attorney, but I could see the stress that that role would create for him. And I really took that to heart. The person who got it, who understood where I was coming from, and was really curious and asking good questions, was at the time my 13-year-old son. Well, that son is now 27, and he is my healthcare power of attorney because he gets it. He understands me, he understands the directive I've given, and he can do this role. So picking your healthcare power of attorney doesn't necessarily have to default to your spouse is the point of this. It can be a adult child is kind of a word term for a 27-year-old. It can be a friend, it can be a sibling. It's just you need to say who you want it to be. This designation does not require a lawyer. You do not have to notarize this. You do not have to pay big money to do this. You can get the form off the internet or from your local healthcare institution, and then you fill it out. It needs to be witnessed by someone who's also 18 and has no kind of conflict of interest with what you're designating. And once you fill it out, please don't put it in your social security, put it into your secure box. Please don't lock it away. Put it in a place where it can be found. Make sure that copies go to your healthcare providers so that they know who your power of attorney is. Get it out there. What happens when we don't do this? And again, 80% of people will tell you this is really important stuff that Dr. Twaddle's talking about on Saturday afternoon, and then they don't do it. And then what happens is this is me on a Friday at 4 o'clock because a family has to gather to talk about decisions around dad because dad never established a healthcare power of attorney and dad is very, very sick. So there is a surrogate decision-making list that we have to go through legally. We start with the patient. When the patient's incapacitated, we go to the spouse, but many times there isn't a spouse, either because of divorce or death. So we obviously, if there's a healthcare power of attorney, we go to them. But if there isn't one, we have to identify the surrogate. And in the event that there isn't a spouse, that goes to the adult children. The reason for the referee outfit is they all have to agree. There has to be consensus. Not one kid, not just because they're the oldest, is a spokesperson. It doesn't go like that. If there are many adult children, we need them to come to an agreement in the care of the one who is ill. You can imagine how fraught that can be, particularly when people are very ill. And again, the gift we can give our families and those who love us is to designate the spokesperson. This doesn't mean that they lord it over everybody else and make decisions without any input, but it means they are the ultimate spokesperson and sometimes decision maker, and ideally facilitating the decisions that you have made. One of the ways you can indicate what your decisions are to create what's known as a living will. This is a healthcare declaration. You write out what you do and do not want. It's kind of like 5 wishes without check boxes. You just have this language about what's important to you in your medical care. Traditionally, folks have a living will that speaks to the terminal phases of their life. That's the greatest purpose of this. And they may make declarations that in the event that they are terminally ill, they do not want their life artificially prolonged with machines or medical interventions that are not beneficial, that don't promote the well-being that how they define well-being. There's a challenge. So this is great, and I want this information from my patients, but this document is not actionable. So what I mean by that is a patient whose mother, actually friend whose mother lived out of state, who had far advanced heart disease. She was widowed, she lived alone. She had a living will. She had her document for her healthcare power of attorney. She had very clear directives as to what she did and didn't want done at the end of her life. One morning she woke up and she knew, whoa, something's going on with my heart. She was nauseated. She was intermittently sweating. She felt kind of short of breath. So she made sure that the breakfast dishes were washed and the dishwasher was emptied. Seriously, she put her living will and her healthcare power of attorney on the kitchen table and she called 911. And she said, please come to the kitchen door. It's unlocked. And the next thing she was conscious of was she woke up several hours later in an ICU with what's called a balloon pump in her groin on a ventilator. So, how in heaven's name could that happen if she had a living will and a healthcare power of attorney? When we call 911, we are giving consent for treatment, and the response team are paramedics, and paramedics are not physicians. Physicians aren't part of those teams. They cannot change their protocol that you have given consent for with your phone call. They can't change it if there are documents in the home that would tell them something. They can't stop and read your living will and adjust their care plan. They can't call your healthcare power of attorney. Those pieces don't change their protocol. The only way to change their protocol is to create a document called a POLST, Practitioner's Orders for Life-Sustaining Treatments. In some states, this is called the MOST or the MOLST. It's got different acronyms. Basically, what this is it is a practitioner or physician order that is in your home that the emergency medical system can see, and they can then align their intervention to be consistent with what you want versus their protocol. So if you've said, I don't want to be on a ventilator, they will not do that. They will not do CPR if you say, I don't want CPR. But the only way you can make sure that those things are avoided is by having this document. Typically, people will put it in a plastic bag in their freezer. There are 3 reasons for this. One, it's kind of icky to put it on the front of their fridge when socially, like a declaration, like Martin Luther's papers or something. Putting it in the freezer is such an odd thing to do with the medical directive, and typically put it in a plastic bag, is you're not going to forget it's in the freezer. And the other thing our firefighter friends have taught us is that, God forbid there's ever a fire in your home. Did you know documents in your refrigerator freezer are likely to make it through any fire because of the refrigerator? But the other piece is because it's odd, people don't forget it's there. And the paramedics often will look in your freezer to see if it's there. This has gotten to be kind of a cultural thing that we do. The PULSE document gives information about whether or not you want CPR. If you're found to have died, if you're found to be in cardiac arrest, you have no pulse and you're not breathing, this tells the paramedics whether or not to attempt resuscitation efforts, to do CPR. That is not the same. By saying I don't want CPR does not mean to say that if they find you in distress, you say, I don't want CPR, but if you find me in distress, if you find me struggling to breathe or having a heart attack, I might want everything done. So this is what people don't realize is you can say, don't resuscitate me in the event that I die. But when you find me alive, do everything you can to keep me alive. Put me on a ventilator, give me drugs, take me to the hospital, put me in ICU. That's called full treatment. You have a choice on the POLST to be full treatment, limited treatment, which typically means don't put me on a ventilator, or focus just on my comfort, get my family out there, don't transport me ideally unless you absolutely have to, do comfort measures only. There is a section on the post about nutrition that really applies to people who are living in long-term care facilities. It's, paramedics don't start you on a feeding tube. So it's kind of, I tend to cross that section off for any of my patients that live in a home setting. But this is critical. If I have very strong feelings about whether or not I want certain interventions done to me, and particularly in the event, a lot of my patients will say, when I've died, please don't mess with me. Respect that. But if you find me alive and while life is present, do everything you can to support my life. And you can have both. Having these things documented greatly improves outcomes that are valued by people and their families. Things don't happen just to them. Things happen that support what it is they want. It reduces the medical errors to have more documentation around what I want when I am very ill and what I want if there is a medical emergency. And the pulse obviously is critical if we want to actualize limiting interventions from paramedics. Bottom line is, what a person values is what we want to hear. What is it I need to know about you to take the best possible care of you? And how do we then also make sure that that gets into our medical record, that is spread beyond just the person that we're telling this to? Sometimes we worry that if we have these conversations, that if we bring it up with our mom, she's going to lose hope. I hear that. If we talk about this, it's going to scare her. Or if we talk about this, she's going to give up. Actually, that has been found not to be true. Most people are very aware that they're very ill, and they don't sometimes know exactly how to bring it up for fear that they will scare or upset those who love them. So we tiptoe around what I call not just the elephant in the room, it ends up being the mastodon in the kitchen, in order to try to protect each other. When what we found in studies is that having these discussions actually improves anxiety and depression, not just for the person who is ill, but for those who love and care for them. So in one of the studies, just an example, end-of-life discussions were found not to be associated with worsening a person's emotional state. If anything, it seemed to relieve anxiety and help people to feel more empowered and confident that their care was going to be what they wanted and that their family members were okay. End-of-life discussions were associated with typically understanding and accepting an illness and how serious it was. Many times when people had deeper understanding, particularly at end of life, they chose comfort-focused care versus interventions that would not necessarily benefit them or might introduce new symptoms. And many people in these situations would establish, again, this do not attempt resuscitation status with modifications on how assertive or aggressive they wanted healthcare to be before they got to that point. What I also found fascinating in this study and others is that when the survivors, those folks where these discussions have not occurred, those folks who felt they were thrust into decision making without any preamble and they'd never talked about this with their loved one, they were much more likely to develop depression and post-traumatic stress. They were more likely to experience a sense of regret and fear and anxiety after the fact, and their quality of life and self-reported health around the event and after the event was much worse than those folks who had had conversations with their loved one about advanced care planning. So what does it mean to me? Having these advanced care planning and certainly discussions about end of life meant that most folks then chose a less interventionally based medical care plan or more a comfort focused plan of care, and they express higher quality of life at the end of life. And those who love and care for them, who experience the loss, had improved bereavement outcomes when they had had an opportunity to talk to that person before they died. So having these discussions is not associated with worse outcomes. It's actually associated with better outcomes for both the person who is very ill and dies and for those who love them and lose them. So if you remember anything else from this, preparing and broaching these conversations with the people we love in little doses sometimes is very, very important, very critical to our well being. Good medicine is about doing the right thing for the person, and the right thing is defined by what they consider the right thing. We must consider what they prefer. Good outcomes are those that are meaningful to the person. Don't ask what's the matter with me. Ask what matters to me. So in a very short time, kind of a luge ride, I hope we have some time for questions. We've talked about what's the difference between palliative care and hospice. And remember that palliative care ideally is integrated at the time of a serious diagnosis and should thread and wax and wane in intensity and involvement throughout that time. I follow people for years, sometimes decades, with palliative care support. And the outcomes are very exciting when palliative care is involved early. Advanced care planning is a part of what we do. And what this really helps facilitate are your values being actionable and understood by those who love you. When you walk away from this talk, everybody needs to double check. Do you have a healthcare power of attorney? Does that person know that they're your healthcare power of attorney? Have you written it down? And have you talked to them about what's most important? And when illness is far advanced and the likelihood is that death could happen in the months ahead, the years ahead, perhaps that is the time to establish a POLST form. For some of my very religious patients, they will establish this much earlier, meaning, for example, in Orthodox traditions, they do not want interventions after they have died. That would be awful. So they will create a POLST such to protect themselves from interventions that would occur in the event that they die. But they want everything done while life is present. And by creating the POLST, it really sets those guardrails and that directive. Having a trusted relationship with a healthcare professional is really important. Someone we can tell our fears to, we can be honest with. And I ache in this regard because I see such fragmentation in healthcare and way too many people on our team that really don't know us well. So particularly when we are ill, this is where palliative care, I feel like we're the convener of the team and help facilitate patient-centered, family-centered communication and plans through our integration. Our motto at Northwestern's Palliative Medicine and Supportive Care program is to live well and land softly. And that's through this mechanism of integrating early supportive care. So I think we have some time for questions. You see me okay? Let me see.
Yes, yes.
Okay,
All
great.
right. All right. Yes, we do have a time for a question or two. What would you recommend for patients who feel excluded from
Mm.
the discussion with their care team? You know, their care team might be talking about palliative care or end of life hospice, and the patient's present but not being included in those conversations. Uh,
Yikes.
right? Not a good place to be. What would you recommend patients be able? How can they speak up and advocate for themselves, or their caregivers do the same?
So important. Yeah, I can't think of anything more horrifying than to be talked about instead of included in. And you know, it speaks to how important it is to have folks on our care team that we see as advocates, or to have a family member again who can be assertive and communicate and involve. Um, obviously, I feel very strongly that palliative medicine's integration into care plans and our team being not my team because I'm not everywhere, but having a palliative care team being involved when we have a serious illness is so critical because they often are those folks who advocate and raise the volume of the voice of the person who is really the ultimate decision maker. When we have capacity to make our own decisions, we're the ones making the decisions. Nobody else makes them for us. When we don't have capacity, and by that I mean our capacity is impaired because we can't communicate, or we're too ill, or we're delirious, or we've non-communicative because of interventions, then we have to have that healthcare power of attorney. And that's where having that be very tight so that that advocacy and that confidence that we are really our goals, our values are first and foremost in this mix. Uh, yeah, I that would be real. That's like a nightmare in my mind to imagine being in that scenario.
Yeah. We have I've actually gotten some messages from people who have questions, but they're a little hesitant to ask them because this is such a tough topic. But if it would be okay with you, Dr. Twaddle, what I can do is kind of put together some of those questions, and we can have you answer them, and we'll share those with the participants after this.
Absolutely.
Perfect.
Absolutely.
All right. Well, thank you so much. Like I said, this is a tough but like very important topic to discuss, and I'm just glad that you were able to join us today.
It's my joy. And remember, pick your healthcare power of attorney.
Yes, yes, so important, so important.
Yeah.